a short history of New Knowledge Adventures is that it started in the Treasure Valley area in 2015. So it hasn't been very long in the Treasure Valley area, but it started out in Pocatello with in conjunction with AARP and Idaho State University. And then we kind of modeled our program off of that. We have been using Zoom only for the last 3 quarters, or the last 3 semesters, simply because of the COVID. We probably will go back to in-person, and Zoom will do both next semester. This is a volunteer-run organization, meaning that everyone other than the AARP staff are volunteers. So those people who are on the curriculum committee, those who are on the facilitator committee, those who are on the venue committee, all of them are volunteers, including the people that actually teach the classes. So we thank Dr. Cleveland for coming to us. I actually have heard his presentation once before, and it was extraordinary. I just thought he did a wonderful job. This New Knowledge Adventures, or NKA as we call it, in the Treasure Valley, we are partnered, of course, with AARP and Idaho State University, and we're trying to get a statewide collaboration going. We've been meeting so that we can watch their programs also. Currently, it's for individuals over the age of 50 who have a passion for learning. And so if you like to learn, there are all sorts of classes that you can take. This class will be recorded so that people can go back to it, or you can tell your friends about it. And it's on YouTube, and it's NKA Treasure Valley on YouTube. And so you can do any of the classes that we are doing this semester and last semester. The class will be recorded, and there's only a couple ground rules. You can come and go as you please during the class. You will be muted, except there may be times that we will unmute you, but mainly we mute because there can be some other noises within people's homes that we probably don't need to share with everyone. That we ask that you use professional language and behavior during this, and questions will be asked in the chat box, and Dr. Cleveland will answer those. He'll actually be monitoring the chat box also. Dr. Cleveland, as I said, is an associate professor at Idaho State University, and he works with the doctoral students at the university. So all those PhD candidates are working with him in some capacity. He has his main interests and knowledge base has to do with immunizations, nuclear pharmacy, med management, and drug information. And the drug information, I don't think most people know that your insurances oftentimes will help you to, or let you have a free consultation with a PharmD, or a doctor of pharmacy. And I will tell you that it's much different than just those little drug information sheets that you read, and they have a wealth of knowledge that I don't think most people even know about or utilize. And you'll find out today what that's all about. So Dr. Cleveland, it's all up to you.
Great. Thanks, Debbie, for that introduction, and welcome everybody. I think I recognize a couple of faces out there. So, so this will be hopefully very familiar information that I'm going to go over today. And I'm really excited to be here again to present this information. And yeah, please feel free to use the chat box to put in questions. And after a while, if I need to take a break to give my voice a rest a little bit, I will also, we can also field questions. And as was mentioned, since I am a professor, I also like to test my students before a lot of times to see where you're at. And so we have I have a poll that'll open up here in just a second, and it will take some time to go through those questions, and you'll answer those questions, and then we'll come back and review those a little bit. So I'm going to open the poll, and let me know if everyone can see that poll. Okay, and go ahead and answer those questions. I think you should be able to navigate through those. There should be like 6 questions.
I think you have to launch each one separately.
Oh, do I? Okay. Can everyone, because I can see who's actually participating. So, okay, we have 1. It's working. And don't worry if you can't pronounce the names or anything like that. So it takes our pharmacy students like 4 years to know how to pronounce these. Okay, there's 1 more person. All right. I read it. Just for time's sake, I'm just going to try to keep these to about a minute. So let's end the poll. And so the answer to this question is really all of the above. That's somewhat of a trick question. So all of these medications really should not be utilized in people over 65 and older due to they can affect cognition, also can affect your ability, increase some other issues like your balance, so increased risk of falls and things like that. So one of the things that we'll talk about that pharmacists will do in a medication review is try to identify some of these medications that aren't, so you could, I didn't realize you couldn't see this, but so all of these above would be the correct answer for that. So, all right. Here's the second question. So what are the benefits of having a medication review done by a pharmacist? Okay, I think. All right, can you see those results? Yes, it's all the above. So one of the advantages of having pharmacists available on your healthcare team is that when we can help lower healthcare costs, we can find cost-effective ways to cost-effective alternatives to some of your medications. There's a lot of evidence out there to say that there's fewer visits to a doctor's office or emergency room by having a pharmacist involved in your healthcare, and helps you understand medications better, and also better management of common healthcare conditions, because people will see their pharmacists about 7 times more often than other healthcare providers, just due to our access. So that's really one huge advantage. All right, the next one I have here is what medication should all people who have diabetes be taking to help prevent heart attack, stroke, as long as there's no contraindication or no reason why you can't take it. So which one of these medications, metoprolol, clopidogrel, atorvastatin, or Benadryl? Okay. I'm going to share the results. So the answer to this question is really atorvastatin, and atorvastatin is a medication that's used for help with your cholesterol. But what they've also found out in people that have diabetes is that atorvastatin has other properties outside of lowering your cholesterol that benefits your heart and your blood vessels in general. So there's some other advantages, even if your cholesterol is normal, that if you do have diabetes, that a drug like atorvastatin has additional benefits to help prevent heart attack and stroke. And so those would also be something that we look at as pharmacists when we go through a medication review, is that if you do have diabetes, that's one of the things that we'll look at. And one of the things that we can actually, here in Idaho, as pharmacists, I can actually prescribe that for you if it's not on your medication list. And so that's independent of a physician as well. And of course, we would also communicate that with your doctor as well. All right, so this next question is kind of a two-part. So when I put this in here, I just realized it's going to be kind of difficult to answer. But what routine immunizations should you be asking about? Let's 65 and older. Let's start with, we'll just do that one. Which ones would you be asking for 65 and older? And then we'll talk about 50 and above. And it probably looks, you probably can only select one, but I should have had one that select all that apply. So I'll just end this one and share the results. So actually all of these is, all of the above would, ones that you'd want to be asking about 65 and older. Tetanus with pertussis or your Tdap, really recommended as your routine tetanus booster. Shingles, of course, is recommended as well. And it starts at 50. The recommendation starts at 50, or if you're people 19 to 49, if you have some kind of immunocompromised or your immune system is not fully functioning, you can also get the shingles vaccine. And now pneumonia, that one's a little, that's new this year. There's a new recommendation. I'll go in more in depth about that because there are some, the recommendation is a little complicated, and I'll highlight some of that, but pneumonia should also be part of the discussion with the pharmacist, and also your flu. What we have are the enhanced influenza vaccines that are for 65 and older, such as Fluzone and Fluad, and I'll talk a little bit more about those later. And then also the new change in the guidelines for hepatitis B. It was really, the recommendation is for people with diabetes, but now they have a general universal recommendation for hepatitis B, which I'll go over as well. All right, we're almost done. All right. If a medication needs to be taken on an empty stomach, how soon after you take your medication can you eat some food? Is it 30 minutes, 2 hours, 1 hour, or 10 minutes? Okay, I think that's So the recommendation is generally 1 hour after you take your medication. The 2 hours is if you eat. If you eat, then you want to wait 2 hours before you take your medications and make sure that you have an empty stomach to allow your stomach to empty. And so we'll talk a little bit about what does that look like with certain medications a little bit later. And then our last question, which of the following do you use to find information on your medications or medical conditions? Is it Google? Is it Facebook, WebMD, or Wikipedia? Okay, I think that's everybody. All right, so WebMD, yeah, that's actually a really good source. If you chose Dr. Google, as long as you know how to navigate Google and get to the right sources. And later at the very end, I'll go over some useful websites that you can utilize, at least from my perspective, are really good sites for you to go to get really good information that's trusted and not from Wikipedia is probably one of the worst places for you to get information on medical conditions and medicines, because about 20% of the information on medications in Wikipedia is incorrect. And so it's really not a good site to go to. And so I'll give you some of those a little bit later. All right. Now the poll should be gone, right? No one can see that? Okay. All right, can you see my slides?
Yes.
Because now okay, because I can't see anybody now. But so for the rest of the time, I will go through a lot of information on medications, and I look at it as, at least if I was just a patient, sometimes it feels like I'm going through a minefield. And so it's really good to have a little bit of knowledge and how know where to step so that we don't get into trouble. And the other thing, I don't have anything tied to this presentation. And then as for objectives, things I really want to cover today, at least I want you to be able to come away from, is to know what to expect from a pharmacist's consultation on specific medication needs. And also, that's one of the things you should be asking a pharmacist for when you pick up your medications too, is to really have them go over your medications with you. Also, a list of services provided by medication therapy management by a pharmacist, because it's a little bit more advanced than just the simple medication education when you pick up a new medication. It's a little bit more in depth and a bigger analysis on the pharmacist side of things as well. And then I had a little thing pop up. You can still see my slides, right?
Yes.
Okay, perfect. And also I'll talk a little bit about what is a complete medication review, or CMR, or a target medication review, which is what is called a TMR, because those are two different things. They kind of come to the same outcome, but their purpose is a little different. And also understand the importance of medication and food interactions, because I think that is one of the areas that, at least when I work in a pharmacy, a lot of patients don't understand how food can actually play a big role in how your medications work, and a lot of medications that people take chronically, and then how you manage those as well. And then understand some of the recommendations that are new for vaccinations. So the CDC has just updated their guidelines in February. So there are a lot of new recommendations, especially for the 50 and older, and then be able to look up medical information on the internet from trusted resources. All right. Let me pull up the chat here. Okay. Any questions so far? Okay. I don't see any in the chat yet, so that's good. All right, I do have a question, and you could type it in the chat, or if if you're allowed to also just chime in by unmuting yourself. What percentage of Americans are on one medication? Does anyone know? You probably didn't think you're going to be going to school today.
No.
90%? Okay. That's pretty close. That's really close. So that you're at 70% of Americans are on one medication. And Chris says 100%. Not quite, because there are some people that don't take medications. And so what about 2 medications? What percentage, or at least are taking 2 medications? I'll give you a hint, it's lower than 70%. 50%, good job, Linda. That's actually correct, 50%. So what's even more interesting is that 2/3 of people 65 and older take 5 to 9 medications, which is a lot. That's a lot to manage. That's a lot to think about every day, especially when we start talking about interactions. So what is your risk of drug-drug interactions, say, with 2 medications? What are the chances of those 2 medications having an interaction with each other? And I'm thinking of percentages. 30? It's actually a little bit lower than that. So we're looking at about 13% chance of having an interaction with when you take 2 medications. Now, what if we go up to that 5 medications, so that that we see in 65 and older? What's the chances? I think, Linda, you're actually really close with your 30. So that's 38%. Now with, say, what about 7 medications? So we're still within that 5 to 9. And most of the patients I have worked with, they're on 7 or more medications. So what are your chances of having a drug-drug interaction? 50%? How about 82? So as you can see, the more medications we add on, the higher the probability will be to have a drug-drug interaction. And that's why it's really important to have healthcare providers really look over your medications. And pharmacists, we can do that and help you navigate some of these drug-drug interactions. And we'll talk about drug-food interactions too, because they can have an impact on how the medications work. So more medications, more likelihood that you're going to have interaction. And that's why it's really important that you do talk with your pharmacist to make sure that what you're taking is not interfering with each other. And sometimes those drug-drug interactions are beneficial, but most of the time they're going to be detrimental to what's going on with your health. So there is a cost associated with this. So basically, for every $1 that we spend on a medication, an equal amount is spent on problems with the medication. So it's a constant issue, and that has to do with what we call adverse drug reactions. So a reaction that you have to a medication. And so some of those aren't predictable. We don't know they're going to happen until you take those, but also non-adherence. And what I mean by that is you're prescribed a medication, but you don't take it as you're directed to or prescribed by your provider. And that can also lead to more money spent, because if you don't take medications as you're prescribed to do, then that can lead to more hospital visits, more doctor's visits, more medications that you have to take. So, and there's also the drug-drug interactions, as we talked about, and then also inappropriate medications too. we had one of those polling questions, which of these medications shouldn't be used. And there's a lot of those medications that are prescribed that can also be inappropriate. So how much is spent on that improper medication use? Anyone want to take a guess? In dollars? If you do euros, we'll have to do a conversion, but. Okay. All right. $290 billion spent and just improper use of medications. And why that's important is that 75.9% of those are actually preventable. So there's a lot of money that can actually be saved in healthcare costs, as I can think of a lot of uses for that money other than spending on healthcare that issues that are preventable. Some other key things to think about. Every year, adverse drug events result in over 700,000 emergency room visits and over 120,000 hospitalizations. And when we think about those two aspects, those are very expensive. Those are in the thousands and thousands of dollars. And especially several days in the hospital is really expensive. 3.5 billion is spent on extra medical costs due to adverse drug events, because some adverse drug events are very serious and lead to extra costs associated with them, and also dealing with any disabilities that can happen from those. And then 40% of non-hospital adverse events are considered preventable. So it kind of ties back into what we talked about, that 75.9% that's deemed as preventable from medication misuse, but those adverse events, 40% are considered preventable. We can actually avoid those. And it's one of the things that as pharmacists, or what I teach the pharmacy students, is looking at the patient's medications before you actually dispense and give a patient a medications, make sure that it's not going to cause any harm or issues with their current therapy as well. So some of the factors that contribute to medication use, and this is just some background information and things that we do talk about in the teaching the pharmacy students, but also that we try to identify with the patients that we actually serve, is that the health literacy. There is the typical reading level for most people is around the 8th grade level. And so understanding very technical or some of the health related literate or information can be very cumbersome and difficult. So by not understanding how medications work, people tend not to take the medication. Cost is also a big thing as well. That's one of the things that I look at when I do a medication review, is what's the overall cost. And it's not just your prescription medication, it's also all those over-the-counter and supplements that people take, because those do cost money and they're not covered by insurance. And so really looking at those and really evaluating those is really important as well. Understanding of the disease and medication, that kind of ties into the health literacy. And because a lot of times people, like for example, high blood pressure is what we call the silent killer, because you really don't know you have it per se until you get your blood pressure measured. And a lot of times people go, well, I don't feel it, so I don't have any symptoms, so why should I worry about it? And really the fact of the matter is that it will impact you pretty significantly. There's also cultural differences. So one of the projects I'm working on is reaching out into underserved populations and different ethnic cultures here in Idaho. And I've learned a lot about how their perceptions of healthcare, and helps me better understand what's the best treatment approaches for them. And so knowing those cultural differences is really important. And Also lack of support and structure. So sometimes there's not a lot of support structure at home that can also lead to medication misuse. Also accessibility issues, like I mentioned before. Pharmacists, people see their pharmacists more often due to increased access. But if you're in a rural state like Idaho, that can be very difficult. I did work on a project that with actually Francois Cleveland as well, worked on a project where we actually identified 5 counties in Idaho that had no pharmacy. And that actually we did a project to actually reach out to those communities in those counties specifically. So, and also unpleasant interactions with healthcare professionals. We all experience those, but those can also impact that, and also therapy related factors too. And all of these things, a pharmacist is trained to help you navigate if you have any fall into any of those categories. And really, why are we? Because we're really the medication experts. We spend 4 years really studying medications, more so than any other health profession. And when we're all together as a healthcare team with the doctor, nurses, physician assistants, we're all working together, you actually get the best care possible. It's because we all bring something a little different. We all have our own little focus training. And so pharmacists really have that, the medication background. And we also bring a unique perspective, because one of the ways when I'm working with a patient is I'm looking at their medications and what they're experiencing is that related to their medications. Whereas the doctor is going to be looking more for, is there something physical causing that to happen? So pharmacists can help in a very different way. Also, changes to the pharmacy profession, especially here in Idaho. Pharmacists have an expanded scope of what we can do now, because we can independently prescribe certain things. So you don't have to go to your doctor's office to say, if you have a sore throat and you want to get a strep test, you can go into most pharmacies now and get that done. And then the pharmacist will then prescribe the antibiotic for you. Same thing with flu. We can do a flu test. And so there's a lot of different services now that pharmacists can do here in Idaho that can actually really help patients get their healthcare that they need without going to make an appointment to the doctor and waiting longer to get that taken care of. So really that all kind of ties into hopefully having better patient health, also improve quality of care, and also reduce costs. And really there's a lot of new models that are being developed. And even I've been practicing pharmacy for almost 20 years, and I've seen a huge evolution in what we can do. And that evolution is pharmacists are really taking that on and really trying to provide more services. And one of those I want to focus on is what is called medication therapy management. So I just want to ask, and you can type it into the chat or you can unmute and just say something, but what is medication therapy management? What does that term mean to you if someone says that? And if you don't know, that's fine. And you can put it into the chat if you'd like. All right. Okay.
No idea.
Was someone going to say something? All right. All right. Well, so medication therapy management is really, it's a very set of distinct services or group of services that kind of more technical terms optimizes therapeutic outcomes for a patient. So basically, as a pharmacist, I want your medications to be doing the best they can for you. And then the other part of that is also going to be your advocate to your healthcare providers as well, to make sure that you are on the best therapy you can be for whatever you're being treated for, and really also discussing those options with you so that you can make the decision on what you think is best for you. And so that is very patient specific, and it's individualized for you. And it's not just kind of like a cookie cutter thing that we do, but it's really individualized for you. And part of that is that we review prescription medications, over-the-counter medications, herbal medications, dietary supplements. And one of the big things too is immunizations, because immunizations are a big area where we are deficient on. Even here in Idaho, we have one of the lowest vaccination rates for a lot of vaccines in general. So who really qualifies for a medication therapy management service? So like Debbie mentioned before at the very beginning, is that if you have Medicare Part D insurance, you qualify to have a medication review done by a pharmacist. And there are certain things that do qualify you. So one, even your physician can refer you to a pharmacist to have that done. Also, if you have medications from more than one provider, so your insurance company, they'll actually review your medications as they're coming in. And then if you're seeing multiple physicians, they'll probably recommend that you have a medication review. And the reason for that is that healthcare providers don't always communicate with each other. And it's really important that information amongst several providers be consolidated so that everyone knows exactly what's happening. And then there's no mistakes or duplicate medications prescribed and those type of things. Also, if you have 4 or more chronic conditions, and so kind of the target areas for that, chronic disease states such as diabetes, high blood pressure, high cholesterol, asthma, osteoporosis, depression, heart failure, also COPD or chronic obstructive pulmonary disease. So there's a lot of chronic conditions that all of those have high cost medications as well. And we also know people that do have diabetes, they also have more difficulty fighting off infections and things like that too. So there's a lot of time and money spent on trying to really manage those patients as best we can. Also, if there's lab values, so outside of normal, can also trigger a medication review. Non-adherence, like I mentioned before, that's not taking medications properly or as prescribed, and that's over a 3-month period. And usually the cutoff level is about around 80%. So if you're missing 20% of your doses over that 3-month period, then that will actually trigger a medication review. And if your costs are more than $200 per month, so if you have diabetes, you're going to get there typically. If you're on a couple medications, you're going to get there with one of those diabetes medication, whether it's insulin or some of the newer medications for diabetes. They're very expensive. They're very effective, but they're also very expensive, and they just want to make sure that that's being utilized properly. So, and then the other thing too is if you're on a high risk medication as well. We talked about this a little bit before, and there's a list out there. And so this is not a list of beer that's available, but it's called the Beers list. And it's the full name is the Beers criteria for potentially inappropriate medication use in older adults. And it's a really big, long list of medications. And it's not necessarily that they can't be used, is that we try to minimize their use as much as possible, or use the lowest dose possible. And some of them we definitely don't want to use because there are issues that are that can come up, such as they can affect your ability to concentrate or remember your cognition. Also, some of them can increase your risk of falls, or you have enhanced side effects, because some of them can increase constipation, also blurry vision, and also dry mouth and other things. So depending on the medication, you can have any of those. So those things are, those side effects are enhanced as we get older, and 65 years is kind of the cutoff that we look at. And then there are safer alternatives are generally available, but there are times that they're not. And so we have to weigh that risk benefit as well, and by talking to patients. So examples of that is diphenhydramine or Benadryl. It's an antihistamine. Now, can you take it for like an acute allergic reaction? That's what diphenhydramine can be used for. Absolutely. But if you're using it for like sleep, for example, a lot of people do Tylenol PM. It's usually there's better alternatives that are a little bit safer if you're going to use it on a chronic basis. And also Zolpidem or Ambien too should be limited as much as possible. That's also used for sleep because it can really affect your memory pretty significantly in 65 and older. And there are safer alternatives such as melatonin. There's some new data out now on melatonin, like 3 milligrams an hour, half hour to an hour before bedtime, actually seems to be pretty effective for most people to help with sleep. But even with that, there's some sleep hygiene and other things that need to be looked at as well to make sure you're doing those things. But those are two examples of drugs, and there's a lot more out there, like I said, and that's one thing that a pharmacist can look at. So how is MTM delivered? There's two different ways. Face-to-face, where you're sitting down and you're talking with the pharmacist, and that's really the ideal situation. I prefer that as well. The reason is it's more personal, and I get to know you as a person, and you get to know me as your pharmacist, and you build that rapport, and that relationship is really enhanced. And I can also visually identify drug-related issues too. For example, when I was doing a in-person medication review with somebody, I asked them about their medication. I said, "Oh yes, I take it. And I picked up the bottle and I looked at it, and they said they took it every day, never missed a dose. And I looked to see when it was filled last, and it was like 2 months ago, and they still had over 30 pills in their, or over 60 pills in their bottle." And I said that you should be almost done with your medication. How come you still have some in there? Like, "Oh, actually that one's hard for me to take at nighttime. I'm supposed to take it at night." And the very simple thing for me was, why don't you take it in the morning? Because you can take that in the morning. There's no reason for you to take it at night. And once they did that, they were then adherent on their medication. So that really helped, because I would not have gotten that, say, on a telephonic MTM, which is over the phone, which is, I think for a lot of patients, that's kind of preferred because you don't have to go anywhere. You can stay in your comfort of your home, but it's a lot more difficult from my perspective I have to be very creative on my questioning about the patient's medication. But both of those are totally adequate. You still can build rapport even on a telephonic. One of the things I do, I try to listen to background noises. And one time I heard somebody they had horses in the background, and I was raised with horses. And so I opened the conversation about horses, and then they also were more open to answering my questions as well, because we built that rapport. So, but those are two different ways that it's delivered, and they're both really effective. So if you're ever offered to do face-to-face, try to take that option, but telephonic is also good. So what can you expect from a medication review? And I'll go through each of these acronyms that are on here as well. And there's some essential components that have to happen with an MTM process. And so there's the medication therapy review, where The pharmacist will go through each medication, asking you, how do you take it? When do you take it? How is it working for you? And it will ask what side effects do you have associated? Do you, and we might be more pointed on those type of questions, but we'll ask those open-ended questions to get you to give us a lot of that information. There's the comprehensive and targeted that I mentioned before. And I'll go into more details what those are. So you have the CMR, TMR, but and then you'll have, and then you'll get a personal medication record at the end, like an updated list of everything you're taking, why you're taking it, how often, and then a medication action plan. So if there's any issues that are identified during that review process, you'll be given certain tasks that you'll need to do, or tasks that as a pharmacist, I will communicate to the physician for them to at least discuss with you and also act upon. So it's actually a little plan put together so that you can get on track with your medication and get the best use out of those. And then there could be, I can do an intervention right away, or I might have to refer you to another person that's more specialized. And then the documentation is also done as well. And then you'll have a follow-up. And so typically when I was running our medication therapy management program here at ISU, one of the things we would do is reach out in a couple of weeks, and also in a month, I'd have students call up and they'll ask, how are you doing with those changes that we talked about? And just kind of gauge on how you're doing. And then did you do what is planned to be one of the other things that we would be asking about. And just to remind you, if you haven't done it, then we'll follow up again and see how things are going. So like I said before, I was going to go over what a comprehensive medication review, because there's two different things, the targeted and comprehensive. Comprehensive is basically what it means. It's an interview to gather information on your medication. And it's like typically takes anywhere between 30 minutes to an hour, depending on the level of severity or the quantity of medications. And there's some reviews that I think we had somebody on 36 different prescription medications, herbal supplements, and there was a lot of interactions that we had to navigate through. But a lot of things that we're going to look at is review the medications and assess for correct, is it being used appropriately? Or are you taking something that you don't know why you're taking it? And that could be just, there's no indication for that. So why should you be taking that? Also, we're going to look at efficacy. Is it working for you? And what side effects and adherence issues that you might be having, and what can we do to help mitigate some of those issues? And then we'll make a list of medication related problems. And then that will lead to that medication action plan that I mentioned before. And I'll have an example of what that looks like here in a second. So a targeted medication review really addresses one specific medication problem, where a comprehensive can have several medication problems or ongoing medication monitoring. And it's usually a targeted medication review is done after a complete medication review is done. And really, as a pharmacist, I have that responsibility to really look at that and assess those specific problems. And then on that, I'll make recommendations and interventions as well. So it's very similar to a comprehensive medication review, but it's just more focused and deals with one thing. So typically a targeted medication review will last about 5 to 10 minutes. So very, very simple. So one of the things that I like to tell patients if they're coming in for a medication review with me, but also if you're going to go to another pharmacist, the thing to help them the best, bring all your medications with you to the review. Bring everything, even over-the-counter medications, supplements, just bring them. And it's just really important that we have all that, so then we have a good picture of what you're doing each day. And also the immunization records is important, because immunizations are medications but it gives us a chance to see what you need. And immunizations, in my opinion, is one of the best preventive measures we have at keeping you healthy out of the hospital, and especially for those preventable illnesses. And then bring any medical records too, especially if you're on blood pressure medications. If you take your blood pressure at home and you keep record of that, bring that as well. If you check your blood sugar or your A1C, which is another measure of your blood sugar, it's just a little different. Bring that information as well, because it really helps us determine if the medications are working as best as they can, or should we be recommending something different? Or if your blood pressure is too low, should we be lowering your dose or taking off a medication? And lastly, the one thing is bring your concerns about your medications. That's like the first question when I sit down with a patient that I ask is, what are your concerns today? And because what I want to do is make sure I address and focus on those concerns first, and then we talk about other concerns that I've identified from my perspective as a pharmacist, but I want at least address those with you. And I find out that's really a good way because that way you get the most out of this and you get what you're expecting. So I'm going to, for a few more slides, I'll go through a few more slides and then we'll take I'd like to take just a few minute break, but you can also ask questions. We can open it up, give my voice a little bit of a rest. But there are 6 areas that we target, that pharmacists target, and these are areas that patients probably need a little extra help and some guidance as well, because they can be very complicated to deal with. And one of them is adherence. So are you taking your diabetes medications? Probably, because we know uncontrolled diabetes can lead to a lot of issues, such as increased risk of heart attack, increased risk of stroke, increased risk of kidney damage. Also, you can uncontrolled blood sugars can lead to those nerve pain and neuropathy. Same thing with high blood pressure. High blood pressure is also HTN, stands for hypertension, but it's high blood pressure medications. Also, that as well, high blood pressure can lead to increased risk of heart attack and stroke. So taking your medications to help lower your blood pressure appropriately is really important. Also, cholesterol medications as well, making sure your cholesterol is under control. And then diabetes treatment, specifically is that cholesterol medication statin that we talked about earlier, is even if your cholesterol is normal and you have diabetes, you should be on a statin medication to help, because it has other benefits outside of lowering your cholesterol. And those high-risk medications that we talked about that would be on those Beers list. And then also immunizations is making sure you're up to date on those immunizations as well. So personal medication records is so after we go through the medications with you, you'll get a personal medication record, and it's really a self-management tool so that you know, okay, and you know what you're taking, you can take that to other healthcare providers, and it acts as a communication aid between the pharmacist and you and your other healthcare providers. So it's a tool to help you communicate. And this is kind of an example, kind of a dated example of what that would look like, but it's something that you can fill out, but the pharmacist at the end of the review will actually give you a printed out version of this. And then the medication action plan that I mentioned before is at the end of that CMR, you're going to get that medication list, but also a little list of things that you'll need to do, and also a list of things that the doctor's going to probably talk with you about. And really, it's a collaboration between the pharmacist and the patient. So you as the patient and me as your pharmacist, we work together on putting something together that's very specific to you, and it's also understandable, and you know what to do. And it should only contain issues that you can accomplish as well. So an example of that, this is what will kind of look like. So what with this patient, we this is a fake patient, by the way, it's not a real person. And basically the patient stated that their simvastatin, they were taking that in the morning. And actually it's best to take that at nighttime because that's when, so simvastatin is used to control your cholesterol. And your body produces its cholesterol at nighttime. And with this medication, it's best to take that one at night so that it works the best. And so, but in that same class of medications is also atorvastatin, and it lasts a little bit longer in the body. So if they want to take something in the morning, we can actually switch to the atorvastatin. So that's basically what this says is, here is what we're going to do. But what they need to do, which is right here at the bottom, what I need to do is we're going to switch your simvastatin from the morning to 1 tablet at bedtime. And then just kind of what to expect. And then it leaves a little blank spot for what you did. And you can actually write that down so that your next review, you can bring that in and say, this is what I did. And it helps with the communication to the pharmacist. And so really what you're going to get is this patient takeaway, which includes that medication list, also that medication action plan, pharmacist contact information. And this is given after the review is done. And provider communication is essential for the pharmacist to initiate that process, but you'll also have a copy of what's being communicated to your provider as well, so that everybody knows what is going on. And then lastly, we have what is called a follow-up, and that is usually the pharmacist will follow up, or somebody in the pharmacy will follow up to make sure that everything, like, how are you doing on these changes? And it's typically done within 2 weeks to a month after the medication review. And also the prescriber follow-up will happen as well, because that way we have continuity between the care as well. So, and the follow-up can be done face-to-face or telephonically, but typically it'll be a telephone call just to see how things are going. Now, is there any questions so far before I go into the last little bit of the presentation? Is everyone still awake?
Hey, Dr. Cleveland, I was wondering, with these medication reviews with you and whatever, do we call you? I mean, how do we get that set up so that we get the review?
So that's a great question. So the question is how do you get a medication review? Do you call or do you get called? So there's different ways that happens. So you can call your insurance company to see, where you can go get that done, or you can go to your pharmacy and ask, do you offer this service, this medication review? And some do, some do not, just because they probably don't have enough people there to actually do that. But for like the work that I do, I actually am contracted with an insurance company, and then they send me a list of patients that qualify for a medication review that month. And then I'll initiate the phone calls and I'll start calling people. The one issue that I have with that, though, is people don't know me. I'm not their pharmacist, whereas you have this rapport with the pharmacist that you go to. So then it's really, sometimes it's difficult for me to do a medication review because people are a little wary of strange people calling them on the phone. But so really those two ways is you can contact your insurance company, see what's available, where, if they have any suggestions where to go, or you can even ask your pharmacist if they're willing to do that for you. And I think with, so my daughter, she's also a pharmacist, and from what she used to work at Albertsons, and I think they have an internal group of pharmacists that actually do these medication reviews. And so those are, and so the insurance companies, based on what insurance you have, and if you use that in Albertson's pharmacy, then you are flagged in their system, and then they will contact you and do that. So, and I think other pharmacies do that. I think like Fred Meyer, Rite Aid, they all kind of have a very similar system that they identify patients and they do a medication review, and everyone's going to do it a little differently. And so what I described is really the ideal situation of how things should be done. So did that answer your question?
Yes, yes, sir.
Okay. I want to make sure. All right. Any other questions from anybody? Okay. Let me take one more drink. All right. Well, this is the fun part. This is drug-food interaction is one of my favorite topics to talk about, especially with pharmacy students and with patients, because the reason why I got interested in this topic is when I was working in a pharmacy, was I would ask people, I typically ask people, what did the doctor tell you about your medication? And a lot of times, well, he didn't. She said you would. And then, but even if you had taken it for a while, I would ask, has anyone talked to you about how you should be taking this in regards to food? And people say, well, no. And I would explain that potential interaction with them. And I said, that's really interesting, because I don't think like this medication was working for me. So I think when we talk about drug-food interactions, it's really not on the forefront when we're thinking about our medications and our diets and how that can really, really impact each other. And really, a drug interaction basically is dismissed and overlooked. And really, it's a result, whether it's desirable or undesirable, because we can have desirable interactions sometimes. Those are few and far between. And because like for an example, there's two antibiotics, they're injectable antibiotics, and you probably will never see them unless you're in the hospital, that if we use them together, they actually are very synergistic. There's an interaction with them, but they both help each other work better. But most of the time we're dealing with undesirable interactions, and that can either be with other drugs, including over-the-counter medications. A common misperception, if it's over the counter, it's generally safe, but that's not necessarily the case. If you think of aspirin is actually can be very problematic and can cause stomach bleeds and other things too, but it is over the counter. Also, drugs can interact with diagnostic tests, can interfere with certain diagnostic tests. We're not going to talk about those. Also, natural products, another area I'd like to talk with patients about is, even though it might be a natural product, doesn't always mean that it's 100% safe. And it's really important that you do talk to a pharmacist or healthcare, just to make sure that that product's not interfering with anything else. For example, somebody had called when I worked at Drug Information Center, someone called about a certain product, and they were told by another healthcare, well, it's natural, it's safe, there's no issues with it. But when we actually looked at their medication list and also looked at the ingredients of that natural product, that natural product interacted with 5 of their medications that could have actually worsened that patient's condition. And so I think it's an overlooked thing too. So it's really important that you have that discussion. I don't have, natural products, I think, have a place, but you just need to make sure that it's just like any other medication, that they're not going to interfere with anything. Because like aspirin, like I mentioned, is derived from a natural product, willow bark. Digoxin, another medication, is used for arrhythmias or heart irregular heartbeats. is derived from foxglove. So it's natural products do have products that we use on a prescription base. Also, medications can interact with disease states as well. Some blood pressure medications can make your asthma medications not work as well. So those are more of the what we call beta blockers, like metoprolol, propranolol, can make the albuterol not work as well, for example. And then food is also another thing. Food can interfere with your medications, but also medications can interfere with your nutritional status as well. An example of that is like metformin, a common diabetes medication, can actually cause your B12, vitamin B12 levels deplete in your body. And so you have to supplement with vitamin B12, sometimes with metformin. So those are some of the things that as pharmacists and also working with nutritionists, we need to work together as well. So, and we're going to focus more on the food aspect of things. So some of the risk factors for drug-food interactions, really it's kind of what we were talking about before at the very beginning. Chronic medical conditions such as multiple drugs, like we're talking about, the more drugs you have, the more chances you are to have that interaction. Also, as we age, as we get older, our bodies don't function like they used to. I'm learning that myself as I'm part of the 50 and older now, that my body just is not the same, and our kidneys don't work. They don't work as well as they did when they're 20. Same thing with your liver, and we also have more increased risk of impaired organ function as well. So that also increases your risk. And then there's also genetic differences. We're all different. And so therefore, our bodies handle drugs differently from each other. And so that altered metabolism and how your body handles that medication is can be affected through those genetic differences. And that's one of the things that as pharmacists, we do train our students to be aware of those genetic differences as well. And also poor nutrition status, altered body composition and functioning. So, and it can be nutrient intake as well. And we'll talk about some of those nutrient intake as well and how that increases your risk. All right, this didn't, there we go. So, and these interactions with food and drug are really important, and having clinical, so really when we think about it, it can either decrease the effectiveness of the drug. So if there's an interaction with the food, that the medication doesn't work as well. And that's where we see a lot of the issues, is that the medication is not working well, and then you get a dose increase or added another medication on, when really the issue is there's an interaction that we can actually mitigate and eliminate based on how we administer the drug in regards to food. You can also have acute or chronic drug toxicity, and that's where you have too much of the drug in your body. And that can actually happen with grapefruit juice. And that we'll talk a little bit more in detail about, because that is a very common drug-food interaction that you probably have heard of. And then also drugs can alter that nutritional status that I mentioned before, that metformin and vitamin B12. But lastly, the big thing is that that drug-food interaction can worsen or contribute to worsening of the medical conditions, which then can lead to increased healthcare costs. So there's some things that we need to consider. And really it's kind of broken down to the macronutrients, or the big components of a meal. And I'm not going to go through like the minerals and other like the micronutrients, but more of the macronutrients. And it's the fat content, fiber content, protein content, and carbohydrate content. Now, by fat content, that can actually affect the absorption of certain medications, depending on if it's a fat soluble, or it does, like the drug can actually easily dissolve into fat, or if it's a non fat soluble drug. If there's a lot of fat, it can actually impede that. So, but fat in general, it's not a really big interaction that I'm too concerned about, but fiber content can be, because that kind of works like a fishnet if you think of fiber, because one of the things that adds bulk, helps with your bowels to function properly. But basically that can bind and actually grab onto your medications and allow it to be absorbed. Protein can be very problematic as well. So protein can either block the absorption of a medication from your intestines, and so it doesn't get into your body, or increased protein in your diet also increases a component in your blood called albumin. And albumin is how that functions in your body. One of the things is that it can bind drugs. It can actually attach to medications. And what happens there is then that medication can't work where it's supposed to. And so if you increase your protein in your diet, you also can increase that albumin content. And if a drug is highly attracted to that protein, essentially you can diminish the effect of that drug. And likewise, if you decrease your protein content, you'd have more free medication, which then can also increase your risk of side effects and that, because it's the free drug that actually works in your body. And then carbohydrate content, that's really kind of it's a very inconsistent type of reaction. It's highly variable, but we're more concerned about carbohydrate content, especially if you're diabetic or have diabetes, then that can have some effect on how well your diabetes medication works. So why is that a problem? So really, if you think about America's food pyramid, I think this is a true representation of what we kind of have to deal with. The medications form the foundation, because a lot of times when I've talked to patients about their medications, like, I feel like I take so many medications actually like a meal. So I thought this meme was really funny. And also that pizza and McDonald's are kind of two of the mainstays on here. And also coffee has its own little place as well. So, but I think there's a lot of truth to this food pyramid. And I threw this slide in here because how I look at the diet and food and its effects, that sometimes I'll ask patients, what is your diet? Tell me about your diet. What do you eat? And so that way I can actually categorize what their diet is based on. Is it a high fat, low carb, high protein? So like an Atkins type diet or South Beach type diet, because based on that, I can then identify which medications are going to be problematic with those type of diets. A moderate fat, balanced nutrition reduction, or an isocaloric diet. So a diet that falls into that is kind of like the zone diet, where each component of those macronutrients, fat, carbohydrates, the CHO stands for carbohydrates, and then protein. Those are all equal in the amount or percentage of calories you take in for the day or each meal. It's very, very balanced. And then you have the low to moderate fat, high carbohydrate, low to moderate protein, and diets that fall into that category is the USDA guidelines. And then part of the carbohydrates that's recommended is more whole grain, more fiber. So we're looking at fiber, more fruits and vegetables and those type of things. So, but we have a lot of evidence about how those work really well. But and then also the very low fat diets, and that's like the Pritikin or the Ornish diet. And with those, you're taking a very minimal amount of fat, which can affect a lot of your fat soluble vitamins. So if you take vitamin A, D, E, or K, and you're on a very low fat diet, the absorption of those vitamins can actually be minimized to where you can be deficient, because you just don't have enough fat in your diet to have the best absorption of those. So really looking at those can at least help me identify areas where you need to be a little cautious about. And it's one of the things that I also teach to the dietetics about, as well as kind of looking at it from this perspective, so that if they're talking, or dietitians talking with you, they can also look at your medication and say, okay, this one could be a potential issue. And I'm going to go over some very specific medications that we see a lot, or they're the top prescribed medications for the most part. And there's some other things that it might not be, but for example, levothyroxine or Synthroid, it's used for thyroid, and its absorption is really decreased from the intestines with protein, because the protein interferes with the absorption at that absorption site. And so really with levothyroxine, it's really important you take that on an empty stomach, typically first thing in the morning before you eat anything, and to allow it to be absorbed first before you eat anything. And so that's usually the best thing, and also to avoid any like protein. And we'll talk about it again later when we talk about calcium. Now, levodopa, that's used for Parkinson's, and with Parkinson's, that's your body's ability to produce dopamine is hampered. And so it can lead to that shaking of the hands that we see with Parkinson's. And so levodopa, what that does is help replace some of that dopamine that's lost. But for that to work, it needs to get into the brain. But with protein, that actually blocks that absorption into the brain. And so then it can lead to that levodopa not working well. And so, and a lot of times when you think about when I've talked to patients, they don't say that they've changed their diet unless you really ask. They're not going to say, hey, I changed my diet. And those are the type of things that need to ask. And then warfarin, it's efficacy. So warfarin's used as a blood thinner. It's a very old medication that's used still quite a bit. Its efficacy is decreased with high protein diets. And that's due to that albumin that I talked about before, how that protein increases that albumin. Warfarin gets bound up and then it doesn't work. And then if you decrease your protein, that frees that up, and then warfarin can be too high and cause your blood to be too thin. So too much protein, warfarin doesn't work as well. So too little protein, warfarin might be too high for you too. So that's when we actually do monitor pretty closely. Now, fiber, and we did talk about that a little bit. So fiber you get from certain foods, your grains, fruits and vegetables, but there can be a decreased absorption from your intestines with fibers. Digoxin, which is used for regulating your heart. Lovastatin, which is a cholesterol medication. We don't see that one used as much, but also metformin. It's actually is decreased with high fiber diets, but with metformin, you do need to take that with food because it can cause upset stomach. So it's really important. That one you just need to take with food, but if you're taking fiber supplements, you might want to separate those out by at least a couple hours. Penicillins, the efficacy can be decreased as well. Furosemide, which is a water pill, helps eliminate water. Can actually be decreased by 46%, the absorption, which is pretty significant. And also acetaminophen or Tylenol can also be hampered, but that one's probably not as bad. And what's interesting with levodopa, here's a positive interaction, is that it actually increases the availability. And we don't know why that's the case, but that is one thing, is like, okay, you might want to have a little high fiber diet if you're taking levodopa. So that's one of those benefit ones that we have. Now, like I mentioned before, with the USDA guidelines and that, more fruits and vegetables. And one of the things, especially I remember growing up with my grandparents, grapefruit was kind of a staple for breakfast, especially on Sundays. Grapefruit and donuts was kind of the staple. But grapefruit can actually interfere with your medications pretty significantly. And it prevents an enzyme in the intestines from metabolizing certain medications, because some metabolism actually happens in your intestines before the drug is absorbed. And so your dosing is based on what we know without any interactions. And so what can happen by that interaction, it increases the concentration of the medication absorbed from your intestine, which then leads to potential serious side effects because you're absorbing more than what's kind of intended. And the thing with grapefruit, if people say, well, can I space it out? No, you can't space this one out. The reason for that is as little as 8 ounces of grapefruit juice, or even half a grapefruit, the interaction starts at about 30 minutes after eating or drinking that grapefruit and can last up to 72 hours or 3 days. So because it takes that long for your body to replace that enzyme that's been blocked by grapefruit, because the component in grapefruit doesn't come off of that enzyme. So it's kind of important, because you just can't take grapefruit. Even if you take grapefruit consistently, it's still not recommended for that, because you're going to still be inhibiting all those new enzymes that your body's coming out, and it can be very problematic. And this is just kind of a little schematic, I put this in here for all the science people that wanted our mechanism, but basically this is how you have a drug here, it's absorbed and it goes into circulation. But if you have inhibition, it increases the amount of drug that's absorbed. So here, what happens, the enzyme is what we call CYP3A4. So the enzyme is working properly. And so you only absorb this little bit amount of what we would anticipate. Here, down here with the interaction, you're absorbing more, which then increases the concentration, which then leads to side effects. And so some of those I want to go over really quickly. So statins, or those cholesterol medications, those have a big interaction with grapefruit juice. Only certain ones though, not all of them. So atorvastatin, simvastatin are ones that I see most often. And grapefruit juice significantly increases the absorption, which can lead to severe muscle damage, or what we call rhabdomyolysis. And what happens there is that basically that rhabdomyolysis is destruction of your muscle tissue, and everything that's in that muscle tissue spills into your blood, and it can clog your kidneys and lead to kidney failure. Super rare to happen. Rhabdomyolysis on its own, super rare, but it does have pretty serious consequences if it's not identified or if it progresses. So really, the recommendation is, I tell people, don't take grapefruit juice if you're on a statin. I have heard people say, well, with atorvastatin, it's not as bad. You can do a whole liter, but it's still, like I said, there's some data out there that even an 8-ounce glass of grapefruit juice can cause an interaction. So I be on the safe side, avoid it altogether. But rosuvastatin or Crestor or pravastatin or Pravachol, those don't go through the same pathway as those other statins. So if you are, say, I still want to take grapefruit, then my recommendation would be to switch you over to a different statin. There's also certain calcium channel blockers. Those are used for high blood pressure. And what can happen is that you absorb more of that calcium channel blocker, and that can cause your blood pressure to drop or have really low blood pressure. So that increases your risk of falls. And so that's really important to keep in mind. And your pharmacist should be able to go over some of those with you, just to make sure that your medication's not interacting with grapefruit juice. Amiodarone, it's used quite a bit for arrhythmias, atrial fibrillation, and grapefruit juice increases that, and it leads to very unpredictable results. It can, and so one of those things is can cause you to have arrhythmias too. So even though it treats it, can actually precipitate it too. And another one is Viagra or sildenafil. It actually delays the absorption of it, but increases absorption, which leads to potential clinical effects. And the big one with sildenafil or Viagra is it actually causes your blood pressure to drop. It was actually initially looked at for treatment of blood pressure, and it was just serendipitously they found out it actually works for erectile dysfunction as well. So, but with that, we have to be careful that the dose isn't too much to cause low blood pressure. And then another one is diazepam or Valium. So your that class of medications, grapefruit juice can increase that, which can lead to a lot of drowsiness, enhanced drowsiness, and impairment as well, cognitive and other things. So usually with diazepam, I tell people not to have anything with grapefruit. So really my advice, if a medication has an interaction with grapefruit juice, you just avoid it altogether is the best approach. But if you want to eat grapefruit or drink grapefruit juice, then maybe switching to a medication that doesn't have that interaction. I'm going to touch on pomegranate juice because you see this a lot, and pomegranate has a little heart thing on it, a heart on its symbol. And then there's a reason for that, because it does have some benefits or heart health benefits. And it has positive effects on blood pressure. It helps lower blood pressure and also helps with your lipids or cholesterol, and is recommended by some heart doctors. However, there's some interactions you should be aware of, is that it does have very similar actions as some of our common blood pressure medications we use, such as lisinopril or ramipril, which are what we call ACE inhibitors. And we use ACE inhibitors in patients that have diabetes or have had a heart attack. Hence, that's why a lot of heart doctors will recommend pomegranate juices. But it's just something that we need to monitor to make sure that your blood pressure is not dropping too much. But the other thing is that pomegranate can have the same, the effect of codeine, because codeine, when you take that, it has to be converted into morphine for it to work. But if you inhibit that enzyme, then codeine is not going to be working for you. Also, fluoxetine, which is a antidepressant medication. Tramadol also needs to be converted in your body to work. And then tamoxifen, which is used for breast cancer, has to be converted in your body in order for it to work at preventing breast cancer. So doing pomegranate juice and tamoxifen at the same time is probably not a good idea. And then we also have similar grapefruit, similar effects or inhibition interactions as with calcium channel blockers and statin that we saw with grapefruit juice and pomegranate. So some other drug food interactions to consider. So calcium, iron, magnesium, a lot, and zinc, even zinc right now, we've seen an increase in zinc utilization due to help, ward off viral infections. But calcium, especially people that have osteoporosis, we need to look at their calcium intake. Iron and magnesium. Magnesium helps with muscle cramps and those type of things. But this list of medication, all of them are reduced. The absorption is reduced significantly if you take them at the same time as some of these supplements that contain calcium, iron, magnesium. And generally, you should separate those supplements from any of these medications, especially your antibiotics, the tetracycline, azithromycin, and your like levofloxacin or ciprofloxacin. Those last two medications are typically used for urinary tract infections, but calcium, iron, magnesium interfere with the absorption of that, but separate those out by 2 hours. But one thing with levothyroxine, you might want to even separate that out even more, like 4 to 6 hours from that levothyroxine, because there can be pretty significant interaction there. But if 2 hours is what works for you, then being very consistent with that 2 hours is really important there. Vitamin K and warfarin. Vitamin K, so how warfarin works is that you have factors in your blood, the clotting factors in your blood that are actually derived from vitamin K in your diet. Your body uses that vitamin K, and warfarin inhibits those clotting factors. So if you take more vitamin K, you'll actually diminish the effects of warfarin. And so it's really important that if you're on warfarin, that your diet be very consistent to vitamin K content. And there's lists out there of vitamin K foods that have, such as mayonnaise has a high vitamin K content. So it's really important that you try to either minimize those or be very consistent with those in your diet. And we also touched on low fat to very low fat diets and those vitamin A, D, and K, so I won't go through those again. So really my recommendation overall, when you're looking at drugs and administering in regards to meals, this is kind of a general recommendation. Medications that need to be taken on an empty stomach, if you take your medication first, wait an hour and then you eat. So if taking things first thing in the morning, take it like when your feet hit the floor, get ready for the day. And then by that time, most people are ready within an hour and then you can eat. But if you eat first, then you need to wait 2 hours to take the medication. The exception, levothyroxine, iron, calcium and iron supplements, you might have to spread that out a little bit more. But in general, if you take levothyroxine first, and so like milk is probably coming to people's mind. If you have cereal in that, you take your levothyroxine an hour later, you're probably okay. It's just really being consistent in how you're taking your medications in regards to your meals is really important as well. Any questions on that before I go through vaccinations? I'm going to go through this really quick because this is also another conversation you should be having with your pharmacist, but I'm going to go over some of the current recommendations and why why those recommendations were made really quickly. But the best site to go for vaccine recommendations is the CDC. They're the ones that every year they look at all the new data that's coming out and what needs to be done. And the focus that we're going to really deal with today is influenza, Tdap or your tetanus and pertussis, COVID-19, pneumonia, shingles, and hepatitis B, and what those recommendations are. So the new recommendations are out there. Those were approved back in February, and they did change a few things, and those were the focus vaccines that I'm going to talk about. But you can get this, you can read this as well, and it's really what's really nice about the recommendation schedule is that if you click on the vaccine, I'll give you some more information. So if you click on if you're on the website, you click on the gray area, it'll take you into more information. And there's also patient-friendly information on there as well. And the other nice thing for adult immunizations, they have recommendations based on certain health conditions as well. So if you're pregnant, immunocompromised, if you have diabetes, if you have chronic liver disease, those recommendations are there as well. So now individually for influenza, the general recommendation is that anybody 19 and older should get 1 standard dose. However, there are specific recommendations for 65 and older, and it's where we have the enhanced vaccine. And so those enhanced influenza vaccine is either the Fluzone high dose or Fluzone HD or Fluad, which is an adjuvanted, has another component in the vaccine to help boost the immune system. And so the advantage and the reason for that is as we get older, our immune system does tend to wane a little bit, or what we call the technical term is immunosenescence. But essentially your immune system doesn't have the fight in it anymore as it did when you were younger. And so both of those vaccines have been formulated to help boost that up a little bit more than the standard dose that anybody 65 or 64 and younger would get. And so, so it's really recommended that you get one of those enhanced vaccines for your flu shot. And the current data on that right now, there's really no advantage of the high dose versus the fluad. They're both equally the same at preventing hospitalizations and those type of things, or severity of illness. So really, if you ask me which one would you recommend, I'd say, well, either one. Just get one of those enhanced vaccines, because the data shows that both of those work really well in that regard. So, and now for Tdap, there's 2 vaccines for that, is Boostrix and Adacel. Both prevent tetanus and pertussis. You're probably, well, pertussis, isn't that a child, that's whooping cough, child illness, but we can actually be carriers for pertussis. And even as we get older, we can get whooping cough. There's been several patients that I've talked to, they've had whooping cough in their 70s. And so the other thing about having that pertussis component is that if you're going to be around young children, like grandchildren, or just young children in general, having that extra pertussis component with the tetanus protects them and also protects you as well. So any adult 1 dose Tdap is recommended. Then you can get a tetanus, just straight up tetanus shot, or you can get a Tdap again every 10 years. So really looking at that. And so my recommendation, if you're going to be around young children, just get the Tdap. It's not going to hurt you if you get a Tdap again 10 years from now. So it's just that just makes things simple. And and then for COVID, right now, if you've already received the booster shot, if you're 50 and older, you can get a second booster shot. But the general recommendation is anyone 18 and older should get 2 doses. And I'm focusing just on the messenger RNA. The Johnson & Johnson, you can still receive as an initial series as 1 dose. But I'm starting to see more and more just the messenger RNA being used. But it's 2 doses set by 3 or 4 weeks, depending on the vaccine, 3 weeks for Pfizer, 4 weeks for Moderna. And then you have those booster shots. The first booster shot's 5 months after the second dose, and the second booster shot is 4 months after your last booster. So, so really there, and right now a lot of pharmacies do have that available. And then really also the recommendation for immunocompromised people, or if you have an immunocompromised condition, 4-dose primary series is actually what's recommended instead of just the 2-dose with the booster. So do talk with your pharmacist or your physician about that, and this changes almost on a weekly basis, because like that second booster just happened just a few weeks ago. And I got my second booster as well, because I like to practice what I preach. And I think it's one of those things that you should at least have the discussion with your provider. Now, pneumonia, that is, we have 2 new vaccines for pneumonia. We have Prevnar 15 and Vaxneuvance are the 2 new ones, because before it was Prevnar 13 and the Pneumovax 23. And the recommendation is that when you're 65 or older, is you get the Prevnar 13 and the Pneumovax 23. But now that's kind of changed with these new ones. So if you have not done your pneumonia series already, that Prevnar 13 and Pneumovax 23, the recommendations are 1 dose of Prevnar 15, and then 1 year later, Pneumovax 23, or you do 1 dose of Vaxneuvance, and because that Vaxneuvance will still cover you for the bacteria that causes pneumonia. And the reason why the Prevnar 15 and 23 is that in order to have adequate coverage, you need both of those. So, and it really kind of comes down to what's the best cost for you, and also the insurance. So really my recommendation, if you're to make things easier, I'd probably go for the single one, but you wouldn't be wrong doing either or, depending on what's available. So the question is, if you've had the Pneumovax 23 and the Prevnar 15, do you need the Vaxneuvance? No, it's either or. So it's, if you get the the two, the Prevnar 15 and the Pneumovax 23. Or if you had the Prevnar 13 and the Pneumovax 23 previously, which was the previous recommendation, you don't need any of these at all. So it's only people that have not received any of their pneumonia vaccines since 65 and older. So, and so really talk to the pharmacist to make sure which, you know, if you do qualify for that. So hopefully that answers your question, Chris. That's a really good question. And we do have one on grapefruit and pomegranate juice. What about eating the fruit? Yes, the fruit still has those interactions, so you need to be careful about that. So if you had Pneumo 23 and it's been over a year, did you also receive the Prevnar? So it also depends on your age. Did you receive the Prevnar 13? And we can, and that was from Maya Jesse. So it depends on your age. So you have to look at your age and no other vaccines. So really, you probably would. So depending on the timing, so a lot of it, this one is really messy with how they've kind of came out with this recommendation. So you could essentially a year later get, you can do Prevnar 15 or you can do the Vaxneuvance. That would probably be my recommendations, probably in a year, get your Vaxneuvance. And just looking at your history, that's one of the things that pharmacists, we can actually look at your, if you have your vaccines in the IRIS, which is the vaccine registry in the state of Idaho, we can look at that and see what you need and have that one-on-one consultation. So, I mean, it's not asking more. I need to ask more questions about that and where you're at, and also look at your profile to what would be the best thing. But you almost probably would qualify for one dose of Vaxneuvance, or if you wanted to get the Prevnar 13, you might have to go, depending on when you, and the spacing of the Pneumovax, you might have to get that one 3 years after your Prevnar 15. So it's really, would the insurance cover the, possibly, more than likely it would cover the other one, the Vaxneuvance, but you might need to wait a year. That's how some of the insurances will work. And that's why we have, like on this first part right here, one dose of Prevnar 15 and 1 year later Pneumovax, really kind of comes into insurance. Unless you have a certain condition, you can actually shorten that recommendation. And so some of those are people that have immunocompromised conditions, or if you have, I'm trying to remember the other ones, but you can shorten that duration in between the two. So that's one of the things you can also talk to your pharmacy about. Will insurance cover it? They can run that for you and do a test claim and get that for you. So really my recommendation is like looking at what conditions you have and those things. So another question is, how would I know if I had a Tdap? Doctor might have it. So, and the other ones, doctor have those records. They could have it, but like I mentioned, that medication registry that we have here in Idaho, it's called IRIS. All pharmacies pretty much upload any vaccine that you get in that pharmacy into that. That was true with COVID. All COVID vaccines had to be reported. So it's not mandatory that providers upload vaccine into that, and it's strongly recommended it does, because that helps that communication between providers. But really, it's the checking on IRIS, and you can have the pharmacy can actually look your vaccination records on IRIS, and then from there, if nobody knows, or you can't remember when you last had it, or if you've had it, it's not going to hurt you to get it again, that Tdap. So in that case, if we have no way of knowing when, if you've had it, I would recommend getting it. It's not going to hurt you, because in pregnancy, for pregnant females, it's recommended they get a Tdap every pregnancy. And so essentially you can become pregnant a year after your previous again, and then you would get another Tdap as well. So you can get it in a shorter frequency than that 10 years as well. Shingrix, Basically, that's for shingles. General recommendation at 50 years and older, 2 doses separated 2 to 6 months. And they did expand the guidance on this. If persons that are immunodeficient or immunosuppressed, either by illness or medical therapy, they also recommend that as well. So all the way down to 19 years, and they've opened that up as well. So if you know somebody, it's a great idea, because also as we get older, the chances of shingles increases, and it's almost 1/3 of people 60 and older will get shingles at some point. And Shingrix, or the shingles vaccine, is a great way to help prevent that. But if you do get shingles, it actually lessens the severity and also helps minimize some of that nerve pain that can happen from shingles. And if you've ever known anyone with shingles, it is the most miserable thing. Hepatitis B, now that was until February. It was just really, we would promote that more in people that have diabetes, because when they're testing their blood sugar, they have a high risk of blood exposure to blood. And but now there's a general recommendation that all adults aged 19 through 59 years of age should have a series, their hepatitis B series. And it's either a 2, 3, or 4 dose, depending on the vaccine. The only 2-dose hepatitis B vaccine is the Hepasave B, and your Energix B, Recombavax HB, and Twinrix, that can either be a 3 or 4 dose, depending on timing and those types. So best to talk to your pharmacist to make sure what would be the best thing. I like the least amount of things, and if your insurance covers it, the 2-shot series is usually best. But now for 60 and older, it's also recommended for people that are at high risk. Those are people with chronic liver disease, HIV infection, sexual exposure, so multiple sexual contacts, high risk of exposure to blood, so diabetes, or if you're working in an area where you can have an exposure to blood, IV use, IV drug use, for example. And then also incarcerated people, and also travel to areas high endemic of Hep B, and you can actually search the CDC for that. And then also anyone at age 60 or older who does not meet risk-based recommendations you can still make that decision. Hey, I still want to get that. I'll answer your question about the chickenpox vaccine in just a second, because I want to go over a couple of things before we run out of time. So we're going to send out some handouts as well I'm going to also make my slides available to everybody, but also I have a sheet that has useful resources and the links to those, and I'm going to briefly go over those. And these are resources that I know are very trustworthy, and places that you should go to get information on your medical conditions, your drugs, and those type of things. Because I know it's very easy to look up in Google and go to what I tell the students, Dr. Google. And surprisingly, when I ask that question to pharmacy students when they get into the program, I ask them, where do you go to get your information? And 80% of them say, well, I use Google. And so we have an exercise in class to show them how Google can actually lead them to the wrong place and get the wrong information. So it's really important that you know where to go, and that's trusted. And of course, talking to your healthcare providers, your doctor, your pharmacist, nurse, whoever, that should be your primary source. But if you want to look things up on the internet, here are some great places. For general drug information, like how does a drug work? What does it use to treat? What side effects should I watch out for? Medline Plus has some really great information in their drug information section. And also drugs.com is really good too. And if we have time, I'll kind of go to these as well, but you can go to these and kind of navigate yourself. And really, that's the big thing, and they're easy to navigate. WebMD is just general great medical information, and it's put out there by healthcare providers, and it is peer reviewed or looked through to make sure that it's accurate. Because like I mentioned before, Wikipedia, there's a lot of misinformation. Also, drugs.com pill identifier. So if you find something, you can actually go here and type in what the description of the drug is, and it'll tell you what it is, or the tablet, and it'll tell you what it is. So it's very useful. But I also recommend that you call your pharmacy and have them identify it for you as well, because it only takes them like 10 seconds to do. And then there's medication adherence aids, and MediSafe. And what these, if you're having trouble taking your medications on time, these are aids to actually help you with that. MediSafe is an app that you have on your phone that will remind you it's time for this medication, it's time for that medication. And then it can also sync to your doctor's office or even some pharmacies so that they'll tell them that, hey, you're taking your medications or you're missing. So and it's just more of a communication tool. And you can also set up a thing called Med Buddies, where if you don't take your medication, it'll actually send a text message to your Med Buddy, say, hey, this person hasn't taken their medication. You might want to remind them to do so. So it's just a way to help people take their medications as they need to. And then also Hero is a new thing that I came across, that it's actually a device that dispenses your medications when you need them. And it also tells you and reminds you that it's time to do that. And it is a service. It does cost money, but that can also help save money in the long run. And then some other places to go for like diabetes, if you need more information, American Diabetes Association, their website, they'll have a practical guide on how to manage your health and also what to expect when you have diabetes, and that it's totally manageable. And they have some tips on how to live well while you have diabetes. And then also for blood pressure, the best place to go is American Heart Association, also the Mayo Clinic. They have some great information on how to manage your blood pressure as well. Any questions? I know I have a few in here. So it says I had several removed for various reasons. Is there a way to pre-research where a med is made? That's a really good question. So most of the medications that are available in the United States, they have to meet FDA criteria for manufacturing. And then based on that, you're probably referring to the ones that were taken off the market because they had some kind of, during the manufacturing process, there was a byproduct that was created that had a concern that exceeded a certain level. And so with that, that had to deal with more of how the drug was made and just the byproduct that was still present in the manufacturing process for that. And so what they'll do, and then they've taken it off the market, and then products that met that criteria or below that criteria. So there's certain criteria that the FDA puts in place that companies have to meet. You can't exceed this or this. And so that is standardized. And then for like drugs from foreign countries, it's really hard to say what the criteria, the manufacturing criteria are. There's an organization called the United States Pharmacopoeia, or USP. They have a set of international standards on manufacturing, but a company does not have to adopt those, for example. So, but if you see that labeling like USP verified, that's a good sign. And you'll see that on some over-the-counter medications too, and supplements. But in general, the FDA does look at that, and they will do inspections at facilities. And if they're outside of those safety parameters, they will shut them down. And that happened with some like flu vaccines previous years and others. So, and I think that even happened with one of the COVID vaccines, that there was an issue and they shut it down and they removed everything off the market. So, So that kind of, hopefully that answered your kind of where meds are made. You can look at the best place. You have to contact the manufacturer and see where those are made. And then the metoprolol, I haven't kept up on that one. So I'm not really quite sure how to answer that question. So I might have to look at that a little further. Can you expand on that, what you've heard? Anyone? Because that's really interesting. I haven't heard of that. That's
Maya and Jesse, if you could, I'll unmute you. And or I'm trying to unmute you. I don't know if they're still there. Maya, it's Maya, Jesse, and Marty. They may be gone.
Yeah, I think Lesta is the one that asked about the metoprolol.
Yeah.
Yeah,
Oh, yes, is the one? Okay.
yeah. She
Oh.
should be unmuted if she's there, or they, so.
I didn't ask the question.
Yeah. Oh, the ARBs or ARBs. Yeah, it had to deal with there's a byproduct during the manufacturing that there was a certain compound that crossed the threshold that they like to see. And so that's why certain ones were taken off the market, which then minimized the supply. And then we have to switch somebody to a different medication that's just as effective or doesn't have that issue until they figure out how to get it down below that threshold level or eliminate it altogether. So, because I think that the compound I think it was in animal studies, there is an increased risk of certain cancers or things like that.
I remember something about it, but I don't.
Yeah. So it's in those situations, it's just out of abundance of caution, and probably the threshold level is probably way below where you'd probably have a problem as a human, but in animals, it did kind of show those things, or we know that this compound causes these things. And so out of caution, they either recall those medications and then either get switched to something else similar or a different class that works kind of the same way. So another one, if you can tolerate ACE inhibitors, are a good alternative to ARBs or ARBs, which is like losartan. So that would be one of my recommendations. If you can't do it, then we switch you to another one that has the same benefits. So.
Any other questions? Well,
yes.
Oh, go ahead,
Go
Jackie.
ahead, Jackie.
Okay. So I'll see if I can be clear about this. I am a very pro-vaccine person. I always get my vaccines, but I've heard for years about colds and flu and now COVID that, if you're never exposed to it, that you can become more vulnerable. Like if you never get a cold, if you never get the flu, then it can really hit you hard. Is that true? I mean, I guess we can't really know too much about COVID yet with that, but just kind of wondered what your thoughts are on that.
Sure. So just repeat your question. So if we're not exposed to that, like the flu or cold, that when we are exposed to it, even though we've been vaccinated, right, we can get it worse. So, well, this is what I know. This is kind of my thoughts on that is, well, with the vaccine, you still have some protection. And because what happens with both flu and COVID, what we do know is that they do change from year to, well, with COVID, it seems more frequently than every year, but flu does change from year to year. And that's why we have to get a yearly flu shot, because that flu virus does what we call mutate or change based on, it's like, oh, wait a minute, I can't infect people, so I need to change so that I can, because what viruses want to do is they don't necessarily want to kill you off, because if they kill you off, then they essentially die because they need you. But what they'll do is they'll change so that they can actually still propagate or spread. And so yes, so if even getting vaccinated and you isolate and you come back, what you've been vaccinated for is going to be, you're going to be vaccinated for something different than what is actually going to be present. And so then, yes, because your body's like, doesn't recognize it, or your immune system doesn't recognize it. So you can potentially get sick. But what we've seen with COVID is the people that are vaccinated, even if they do get infected with COVID, it's not as severe. And that's the advantage of the vaccine, is to make it, vaccines aren't 100%. They're not a full Band-Aid or prevention. There's, some of them are 30%, some of them are 60% at preventing, but the whole idea is to prevent the severity and decrease that so that you're not as sick and you don't have to go into the hospital. And so hopefully that answers your question. It's kind of, it changes because the viruses change. And that's what we're seeing with flu and with COVID. But some viruses, like the ones that cause the measles or mumps, they don't change as much. And so that's why we can get by with just 1 or 2 shots in your lifetime and you're covered forever, because they don't change. Whereas these other ones, they change so frequently, and then you can get pretty sick, but not at, you won't, hopefully won't be as severe because you have been vaccinated at some point.
Okay, thank you.
Yep. And so I did have one question in here, expert opinion on switching. Is it best to go with an older or newly manufactured? And they have, have an ACE allergy. So in that case, there's another one, there's another agent that's a little bit more expensive in that same category, or not in that category, but it's works a little different, but it's also expensive. So you have to look at what you've tried and what was going on and what that allergy truly was. Probably would stay away from another ACE inhibitor, as would be my recommendation. And I'd have to look at your whole history and what else has been tried in order to make but I like to use older medication. I think older medications are just as effective. Just because it's a new medication doesn't make it better. But that's why we have new medications, because there was a need for that. So a lot of that is really talking it over and what's the best thing for you. So. And a question on pomegranate and simvastatin. I would probably avoid pomegranate juice and simvastatin just in general, because there is that potential interaction with that same kind of enzyme with grapefruit juice and that you see. So if you want to do that, there's another option. You can go, I would recommend either like Crestor or rosuvastatin that doesn't have that interaction.
Well, Dr. Cleveland, again, you did a fantastic job.
Well, thank you. I enjoy this every time. Great questions. Hopefully everyone stayed awake.
Oh, you were very, very good. Thank you very much. And thank you all for attending. Now, remember, we still have programs going on through the next couple weeks. Next week you can there's the pesto making and growing your own basil. There's who gets grandma's yellow pie plate, and that's taught at University of Idaho Extension Service. Build your own charcuterie board and wine tastings. Then there's a digital privacy and security, and then making beeswax food wraps to decrease waste and the use of cellophane wrap and tinfoil. So those are, all you still can sign up for those classes, and we invite you all to attend and sign up if you'd like. I think you have another couple. Oh, there's some more thank yous.
Oh, thank you.
So evidently they didn't fall asleep and they like it. Thank you all very much.
Yeah, thank you. Have a wonderful weekend.
You too, doctor. Bye-bye.